connection nahi hai, that's all.
Okay, chairperson is also supposed to mark.
Hello, good afternoon, everyone. I welcome you all to another session of Think Under the Apple Tree, being conducted by AIOC2024. I'm Dr. Tinku Bali, member North Zone ARC, and I'm sure this is going to be another very interesting and innovative session. I welcome all the people up here on the dais, our chairpersons,
Co-chairperson.
Dr. Ragini Parekh and Dr. Niladri Saha. Welcome. Welcome, ma'am. Our co-chairperson, Dr. Sudipta Mitra. The judges, Dr. Jyotirmay Biswas, Brigadier Shyam Sundar, Dr. Manvi Sindal, Dr. Smita Shukla Singh, and Dr. Koyal Chakrabarti and Dr. Santosh Bede. So we have 9 presenters in this session. So just to remind you, each presentation has to be for 4 minutes, and we'll be having 2 minutes for discussion. So with that, I request all the chairpersons and judges to kindly take their seats on the dais. Do we have enough chairs, or do we need more chairs? So I request the chairperson, Dr. Ragini Parekh, to please call on the first speaker so that we can start the session.
The first speaker is Dr. AIOC2024, and presenting deep learning classifier for screening and diagnosis of diabetic retinopathy using a simultaneous fundus and OCT images. Is Dr. AIOC2024 here? Okay, great. All the best. Thank you, Tinku ma'am.
Good afternoon, everybody. I'm going to be presenting a deep learning classifier for screening of diabetic retinopathy. So the problem that we are trying to address is the increasing loads of diabetes and hence the need for diabetic screening. In India alone, there are more than 73 million people who are diabetic. It is said that out of every diabetic, every third diabetic has diabetic retinopathy, and every 10% has a vision-threatening diabetic retinopathy. But because of delayed referrals and lack of adequate healthcare infrastructure at the primary healthcare level, the screening is impacted. So we wanted to make a model for early diabetic screening, which can be implemented at ground root levels and is an easy, reproducible modality, which can be accessed and implemented by even untrained personnel, staff, or even physicians. So for this purpose, we made a deep learning classifier which used simultaneous imaging with a fundus camera and an OCT imaging for screening of the retinopathy. So we used about 3,165 fundus images and 4586 OCT frames from 629 diabetic retinopathy patients who were visiting our center. All these images were annotated separately by 2 retina specialists. Then these images were fed to a deep neuronal network screening model which classified these images as normal and abnormal. Abnormal pathologies from these scans were extracted as image patches, which were then fed to a pathology model and which classified these abnormal images into various things like fluid-filled regions, hemorrhages, hard exudates, or traction, which helped us classify the patients into a referable or non-referable pathology. So this was our general working of our AI system, which used the input from a OCT and a fundus camera, first which was processed through a gradability and localization network, which localized the areas of pathology, and then it classified, it went through a classification network, which classified it as a referable or a non-referable pathology. Referable was, for us, we had classified it as a severe non-proliferative or a proliferative diabetic retinopathy or patients with diabetic macular edema. These were the fundus photographs that we used. The hotspots were marked, and as you can see, the abnormal images like hard exudates, neovascularization, or laser scars were identified by the model. And these are the localization maps for fluid-filled areas and epiretinal membranes that the AI model can now recognize. So using this model, we saw that the precision and the sensitivity for grading the non-proliferative and proliferative diabetic retinopathy was approximately 0.9 and above, while the sensitivity was a little less for mild diabetic retinopathy. For severe and proliferative stages, the AI was comparable in identifying these sources. This is the ROC curve for the fundus images and the precision and recall values for different pathologies that was seen. So I would like to conclude by saying that this deep learning network was successful in our primary, in our ground root level to identify abnormal images. And this platform achieved a good performance, especially when using the fundus camera and the OCT images simultaneously. So we feel that this can be used later for screening in a primary healthcare setup. We want to probably put it in use this method with different other machines. We use a Tritron OCT and fundus camera right now. We want to use and see if they can be used with handheld OCTs and fundus camera, and if this can be applied by the untrained staff and personnel. This is what we are working on. It can also identify the drusen's in ARMD. We need to work on it and develop it further. Thank you.
Dr. Ayushi, definitely a very good work, no doubt. I have some questions. Was your output based on both fundus images and OCT?
We did both ways, ma'am. We did separately also, and separately also both of the, individually both modalities were successful, and when we combined, the results were showing higher precision values.
Fundus photograph and its utility to diagnose referable versus non-referable is quite well known.
Yes, ma'am.
What is the possible implication of using this for OCTs?
Ma'am, two things that we concentrated on was the macular edema, showing the fluid-filled regions or intracystic spaces, and the second thing was epiretinal membranes that we were able to localize, which is not entirely related to the retinopathy, but we could say, and then could be correlated to the visual acuity and referred accordingly.
So far AI has been used in something like screening purposes, wherein fundus photos are being screened, and we are trying to determine and reduce the burden on an ophthalmologist by screening via fundus images and AI and diagnosing the referable ones. So only those come. We don't need to screen all the diabetics.
Yes.
So, but an OCT is a specific investigation done by an ophthalmologist. So how does an AI analyzing an OCT help?
Ma'am, definitely a Tritron OCT will not be there for a primary healthcare, but if this can be applied to home-based OCTs, handheld OCTs, then we could implement it at a physician level or a primary healthcare level.
So in an earlier session where I was here, one of your colleagues presented a model of a simpler OCT model.
Simpler OCT,
You should try this out on that.
We plan
Then you
to
have
do
something that's worth talking about.
Yes,
Good work. Thank you.
Can I ask one question, please? You mentioned about screening model and pathology model. So
Yes.
which models were used? What software was used?
So the software name I don't know, but the
And is that model specific to particular fundus camera and OCT machine, or that can be used on any machine?
So we have tried it with the other OCT machines also that we have with the Heidelberg OCT, but the maximum data that we have, because we started working on Tritron, that's the data that I've represented, but we have tried it with other ones and it has been successful.
Okay. Thank you. Thank you.
Thank you, Ayushi, for your nice presentation. May I ask Dr. Shantosh Mohapatra? His number is 6, but due to some managing committee meeting, you have to go there. Okay. So, please, Dr. Mohapatra.
Good afternoon, chairpersons, judges, and dear colleagues. I'm here to present my innovation on no-cost suprachoroidal triamcinolone acetate delivery system. This is usable in DME, postoperative CME, or macular edema secondary to RBO or other causes. Why suprachoroidal route? It's because already proven complications like increase in IOP or secondary glaucoma and cataract formation in the intravitreal route and depot steroid systems. So Presuming the scleral thickness at the site of injection at infratemporal quadrant between 900 to 1000 micron, an injection set is fashioned for delivery of suprachoroidal triamcinolone 900 micron deep. For this, we took 22 gauge needle and broken it from its hub using a needle holder without much pressure. The tip is broken as well. A Castrovicius caliber is taken to measure the exact length of a 26 gauge needle from the needle hub till the beginning of the bevel. The same caliper is used to get the exact length from previously prepared 22 gauge needle shaft, which is put over the 26 gauge needle. Triamcinolone is drawn into the 1 cc syringe and the set of the needle thus prepared is fixed to the syringe for the injection after making it air-free and keeping exactly 0.1 ml of residual triamcinolone. After proper cleaning and wrapping, the exact measurement for intravitreal injection is taken as per the length status, and the needle set is introduced into the suprachoroidal space, keeping the bevel up. The 22 gauge shaft behaves as a guard for further penetration of the needle, delivering the drug at suprachoroidal space. Following introduction of the bevel, the triamcinolone is simply injected and the injection site is sealed with a cotton tip applicator. This can be confirmed by indirect ophthalmoscopy, direct examination under microscope, or anterior segment OCT. And this is a representative case where there is a very good decrease in the macular edema. So we went ahead and done a study in 2 centers of Odisha, and a postgraduate thesis was completed based on this. There are 50 cases, and it proved that definitely it is working. And this definitely, there is a presentation just in the previous session, but it is different from our, like they have used malleable IV cannula, but we have used the metal, which is not malleable. So while injecting, it definitely gives better guard. The needle, the bevel was pointing towards the eye in their cases, and it is up so that it is less chance of penetrating inside the eye. And already study is completed, which is under preparation for publication. So definitely it holds better way that yes, it is working. Thank you so much.
Any incidents of any complications, any perforations?
That's why the needle designed in such a manner that it cannot go beyond that 1000 micron, and the outer needle is a metal one. So if it is a malleable one, you extra pressure you can go inside, but here you cannot. So it rarely has any complication apart from subconjunctival hemorrhages.
How is different from that suprachoroidal injection, which is the trial is been done for uveitis, the suprachoroidal injection of triamcinolone acetonide?
So it can be used for the
uveitis.
Yes, sir.
Intermediate uveitis has been tried.
Yeah.
Suprachoroidal.
Any secondary macular edema due to uveitis or alveoli can be used.
6 number. Huh?
But it negates those complications of posterior subtendon.
Yeah.
Any other questions? Otherwise, we'll move. I request the chairperson to call the next speaker, please.
Thank you.
Dr. Ragini.
Call the next speaker, no? Okay, the second one. Dr. Tanmoy Vaidya will be speaking on hidden hazards using novel isolation techniques to unmask endotoxins directly from the intraocular lens.
So good afternoon to everyone. I'm Dr. Tanmay Vaidya from Narayan Nethralaya. Today I'll be presenting on hidden hazards using novel isolation techniques to unmask endotoxins from the IOL. So it all began with a routine day at office where a 70-year-old male underwent an uneventful phacoemulsification with a hydrophilic IOL. But to our surprise, the patient presented to us on POD1 with this picture with an intense inflammatory reaction with an hypopion. Thankfully, the patient responded to topical steroids and was diagnosed to have TAS after an AC tap. So it got us thinking, what exactly was the source of contamination? After ruling out all of these possibilities, we thought, what if the contamination was directly from the IOL? There were similar cases reported in the country during this time with these hydrophilic IOLs. So we did a literature review where we saw these cluster of cases which were directly associated with the intraocular lens with one common link, yes, endotoxins. So these endotoxins are components of the bacterial cell wall which may incite inflammation even after the bacterial cell death. So could there be a more reliable way to isolate these endotoxins from IOLs? So we at Narayan Nethralaya did a cross-sectional study where we took 11 IOLs and divided them into 3 groups. The implicated IOLs consisted of hydrophilic IOLs from the same batch which had previously caused TAS. The non-implicated ones were from the same company and the same models, but they had not caused TAS. So we handled them in a sterile manner and transferred them along with the packaging fluid of the blister pack into 2 ml low binding tubes. So herein lied the novelty of our study, where we use leaching techniques, that is agitation of the IOLs for 4 hours at 900 RPM. Before we tested them with a reagent, we made sure that these samples were sterile to rule out the presence of endophthalmitis causing agents. So we used a brain heart infusion broth for 48 hours, and as expected, all the samples were sterile. So then we tested the solution with the LAL reagent. So this LAL reagent is basically an amoebocyte of the plasma of the horseshoe crab. They are extremely sensitive to these endotoxins. So 0.1 ml of the leach solution was mixed with this reagent. It was incubated for 6 minutes. As expected, the control group did not show any color change. But to our surprise, both the implicated and the non-implicated IOL showed a color change. To remind you, the non-implicated IOLs had not previously caused TAS in their batch. So we quantified them using spectrophotometry with a light of wavelength 545 nanometers. The FDA currently regulates the acceptable level of endotoxin contamination to be 0.5 EU per ml. So out of these IOLs, 3 of the non-implicated IOLs and 3 of the implicated IOLs had a concentration which was more than the FDA regulated levels. So clearly these current techniques of testing the IOL-related tasks are insufficient, as evidenced by the presence of endotoxins in both these groups. Leaching is a novel technique which is inspired from geology and metallurgic processes. These techniques are used to essentially isolate microplastics from water and also rare materials from the earth. So it's a process of the solute becoming detached or extracted from its carrier substance by using a solvent. So the novelty of our study was that it was a first-of-a-kind study to detect endotoxins directly from the surface of the IOL. And also it's the only study to detect endotoxins in commercially available IOLs before even the incidence of TAS. So we suggest that such leaching techniques can be easily used by IOL manufacturers to be more reliable in detecting endotoxins in these IOLs, reducing such a cluster of attacks. A few IOLs in every batch can be tested for these endotoxins. The interesting part of this study was that these non-implicated group of IOLs also requires further research as to why they didn't elicit a similar reaction in some individuals. I would like to thank the team, Narayan Nethralaya team. Thank you so much.
So your study is quite elegant, but there is also one can study the putting the IOL in a concavity slide and stain directly with the hematoxylin stain and see the cytology. If you see the polymorphs, it indicates an infection. If you see the giant cells or epithelial cells, that indicates a granulomatous reaction, like that IOL's material is not matching with the surface. So I did a study which was published in Journal of Cataract and Refractive Surgery. I could stain also the bacteria and fungus after destaining them. And this is all very simplistic method. Your method is much more sophisticated and very elegant. So I congratulate you for doing
Thank you, sir.
a kind of study.
So,
which
sir, after talking to these manufacturers, basically, so 15 to 20 IOLs in every batch are being tested with similar techniques. But what happens is that all of these IOLs were in fact cleared by the manufacturer already and were commercially available. So clearly there was some lacunae which was lacking basically in their testing process. So that's why the need for the studies.
What is the cost of this procedure?
So the machine which is basically used, any centrifuge can be used, but this machine, the Eppendorf machine, is around 3 to 4 lakhs. So not necessarily every doctor can use it, but any IOL manufacturer can easily afford this. And we can be like involved more hands-on in the manufacturing process as we use these IOLs very frequently.
You said that you ruled out the other causes of TAS from the, the fluids. And did you test those materials also?
Yes, ma'am. So basic testing was done, and they were also...
No endotoxin.
No, ma'am. And also in these cases, most of these substances are used in a lot of cases. So the fact that they didn't cause a cluster of TAS rules out clinically also, in spite of even if we had not tested these things.
Okay, so we'll go to the next. Any question?
Yes. Yes.
I will ask them the next one.
Yes.
That's true.
Yes. Yes.
So now I request our co-chairperson, Dr. Sudipta Mitra, to kindly call on the next speaker.
Yeah. Our next speaker is Dr. Pujitha S. Pratik Prabhu. Is he there? Okay. Pratik? Yeah. Please.
Yes, prediction.
Hello. Hello. Good afternoon, everyone present here. My topic or my project is on prediction on grading diabetic retinopathy fundus photos by CNN algorithm. Introduction, we live in an era where, in the AI era, where we already know that deep learning is a subset of artificial intelligence, where we humans train the model by giving training in the sense we create CNN, convoluted neural network, which are like neurons of a brain. We train the model with an image and it classifies and gives us an output that this is either that or this. So here we are developing a multi-class image classification where it is giving us an output either as 0, 1 or 2. So the purpose is the primary outcome measure is to build a model and find out accuracy on training with diabetic fundus images. So methods, we took a total of 106 fundus images, which are comprising of 18, that is normal. We categorized it as DR1, 49 NPDR images, and we categorized it as DR2, and 39 PDR, which is DR3. Then we used the software Google Collaboratories, and the steps involved are as follows, and let me walk you through the steps. Here. So we initially took the folder and divided them into training, testing, and validation folder. 70% of photos go to training, 20% go to validation, and 10% go to testing. So now we are trying to visualize images. This is a coding just to visualize one image. So here we are able to visualize a PDR photo categorized as DR3. Now we are actually finding out what are the dimensions of each image. Now after seeing one image, we are trying to see the entire folder. In the first cell, we are trying to visualize the first 10 photos belonging to the normal category, that is DR1. Next coding, we are trying to visualize the first 10 photos belonging to the category of NPDR. DR2. In the next cell, we are trying to execute a program where we are visualizing the first 10 images belonging to PDR category, that is DR3. Now we got all the images. We are augmenting the images so that we are training the model and rescaling the images. we are dividing the images into training, validation, and test images. The test images will not undergo any training. It is used directly for testing. So the model doesn't know what the actual test images are. This is the model of our CNN algorithm, and this is the architecture. So here we are showing that we are using two hidden layers and one CNN layer, and the dense layer is giving an output as 0, 1, or 2. This is where we are fitting the model and we are training the machine. So by 20th epoch, we can see our validation accuracy is around 73.68%. Now we are assessing and plotting how our model has performed. We can see both accuracy and loss. The graphs are very near, suggesting the model has been trained well. And now we are fitting the model, trying to see how it predicts on the validation images. So these are the coding which we are turning. The machine predicts them in a form of an array. And now these arrays are converted into class indices, that is either 0, 1, or 2. By end, we are predicting the validation, confusion matrix, and classification report, which I'll show in the results section. And this is the ROC curve for each category. And now the main part is coding for an unknown image. So here we can see a random image has been taken from a directory belonging to test, that is the DR3. These test images are not trained by the model earlier. Now it is predicting an image belonging to PDR as PDR properly with a confidence interval of 90.03%. So results, this model achieved a training accuracy of 79.45% and validation accuracy of 78.95%, and a good F1 score of 0.67 was calculated for accurately grading the diabetic fundus images. Area under curve in the ROC curve showed values of 50, 54, and 52% for DR1, DR2, and DR3 respectively. Conclusion is, these steps and coding for this model is replicable even for large ophthalmic image data sets, and we can obtain a good accuracy, and this accuracy can be increased by image augmentation methods by adding more layers to this and adjusting the number of epochs and optimizers. Thank you. These are my references.
So what you have done is generated another AI convoluted neural network model to diagnose or for the grading of images of diabetic retinopathy. What is this advantage over so many which are already there available?
The advantage is that, ma'am, this is a simple model which you have constructed using just two convoluted layers and two hidden layers. So the other models which we get are usually built by a engineering department or backed by a department which has a proper engineering assistance. So this was just, we wanted to build a model where we didn't want to depend on anybody and build a template. So this can act as a simple template. Using this as a skeleton instead of the diabetic retinopathy images, if we copy the path of fundus images, like instead of 0, 1, or 2, we can code it for giving the output as 0 or 1, where it can say 0 means it is probably normal, 1 it is probably glaucomatous. And we have already tried the model on fundus images.
Who developed it?
Me and our HOD sir, we sat and...
No engineer involved at all?
No engineering help.
So how did you have the background knowledge to do this?
Background knowledge, we spent times watching, there are so many websites where Geek for Geeks is a very popular website. And there are many youngsters who are training YouTube videos where they're teaching how to classify. Like we started by taking with, the initial video was an animal, whether they're telling whether this is a dog or a cat or a panda. So starting from that, all the codings are actually very complex, ma'am, if you see. We wanted to have a simple coding which you can act as a template. You remove the glaucomatous fundus, put retinopathy, it will classify it. You remove or put keratoconus images or anything, we'll get an accuracy, sensitivity.
Very good.
Did you compare your sensitivity and specificity with any other tool?
Yeah, we compared with the other two, ma'am.
So how did it stand out?
Ours was 78% sensitivity what we got. The other models which had 91, 92 percentages were there. The sensitivity of the same model can be increased by adding image augmentation, which can be next level. adjusting batch normalization is the term which is used, where we usually flip, horizontal flipping, adjusting the image height, width, shape can be done, and this can further enhance, ma'am. So we wanted to show a basic architecture and a skeleton.
Yeah, it's a very good study. I think we are short of time, so we can have discussion at the end.
I'm from JSS Medical College,
Thank you.
final year PG.
Thank you very much. May I ask Dr. Pujita S. Building an axial length prediction model by machine learning process, deploying regression algorithm.
Good afternoon, everyone. I'll be discussing on my project, building an axial length prediction model by machine learning process, deploying regression algorithm. The machine learning is a subset of AI, which process embraces certain algorithms capable of learning and making predictions or decisions without explicitly being programmed. So the conceptual idea of my project is to leverage machine learning regression techniques, specifically the multiple linear, support vector machine, k-nearest neighbor, decision tree, and random forest algorithms. So the unique aspect of this study will be, we will be utilizing the corneal curvatures, both horizontal and vertical, and that will be used to predict the axial length. So we have collected the data of 108 eyes from 108 patients, and the data comprises of corneal curvatures, both horizontal as well as vertical, taken from the Bausch and Lomb keratometer, and the A-scan derived axial length. Now this data set will be now processed into the Panda library, where we, I'm just going to show you a Python notebook here, where we'll be where we are going to use the libraries, so the NumPy, Matplot, Pandas, and Seaborn. So after implementing these, importing these libraries, we are going to mount and load the data set from the Google Drive, which consists of a data set that is 108 rows and 3 columns consisting of corneal curvatures and the axial length. So now the data is explored, where we are seeing the first 5 and the last 5 rows of the data set, and it's also going to give us the description statistics, which consists of the mean and the standard deviation. Now we'll be plotting a scatter plot to visualize the data, which consists of corneal curvatures as well as the axial length derived from the A-scan. So now here we can see that there are few outliers which are present in our data set. So next we are going to remove these outliers and then again see the data set, which will be arranged in a scatter plot as well as box and whisker plots. So next we are going to construct a heat map. So this heat map shows us the correlation matrix, where we are going to see the axial length depends on whether the horizontal or the vertical corneal curvatures. And it can be seen here that the axial length has more correlation with the horizontal corneal curvature. Now we are going to train the system, wherein we are going to define the x and the y variables. X will be for the horizontal and the vertical corneal curvatures, which is a dependent variable, and based on this, the axial length, that is a y independent variable, will be defined. Next, we are going to split the data set into training and testing set, for 70% for training and 30% for testing. Now we are going to fit the model for all the different algorithms, that is the linear regression, support vector machine, k-nearest neighbor, and follows. Now the model prediction is tested on the testing set, which gives us the axial length in an array format. So these are the axial length predicted by the system in all the other algorithms. Now we are going to evaluate our model for accuracy by the R2 score, which shows that there's an accuracy of 0.96 to 0.99 among all the algorithms that we have shown, the highest being the random forest regression model. Lastly, we are going to verify each model on one example from the original data set. So suppose we have taken a KH value of 47.25 and a KV value of 47. Now the machine has given us the predicted values of 23.94 and the actual one was 23.9, which is near accurate. Now lastly, we are plotting the results. So here we have an x-axis consisting of actual axial length and the y-axis consisting of predicted axial length, and we can see that there's in the scatter plot there's almost a linear equation marking that it is almost 100% accurate. So coming to the results, so our data set comprised of equal distribution of both the gender as well as the mean age, and we had the 0.96 to 0.99 accuracy in all the algorithms, the most accurate being random forest algorithm. So this was the scatter plot which we have discussed. So I would like to conclude by saying that our present research established an exceptionally high level of accuracy with the random forest algorithm, and this model has a potential for acting as a template for replicating the entire process on a largest data set, aiming at exact accuracy. Thank you.
Excellent. Again, I can see that you are both colleagues. What is the clinical applicability of this?
Ma'am, we already have AI in our IOL calculations, which is the Hill RBF, but there also we again have to enter the axial length. So in setups where there's a shortage of fund or anything, where we can actually use this small coding template to predict the axial length. And also in cases of doubtful cases, you can always verify with a predicted axial length.
So have you tried using this for IOL power calculation?
Yes, ma'am. We are now next going to use this to also predict the IOL based on the corneal curvatures.
So we'll go ahead since we're running short on time.
May I ask Parthu Sharathi Roy? Is he there? HSK with new characterizations, punched out margin, lamellar cleavage, corkscrew endothelial plaque. Your time is 4 minutes, okay? Please remember that.
Good afternoon, everybody. I'll be presenting my innovation. The title slide is here. I am Dr. Parthu Sharathi Rai, no financial interest to disclose. Herpes simplex keratitis has an estimated global incidence of roughly 1.5 million, including 40,000 new cases of severe monocular visual impairment or blindness each year. However, its misdiagnosis ranges from 9% to 30%. In the foregoing 7 eyes of 6 cases will demonstrate certain unique characteristics of herpes simplex keratitis which were never been discussed in literature. We believe these telltale signs will help reduce misdiagnosis and thus save precious time before initiation of appropriate therapy and save thousands of eyes from blindness. This is the case 1. You see, in A, you can see a deep stromal infiltrate with central corneal ulcer with very precise margin, punched out precise margin with an endothelial plaque. In B, you can see the profound loss of corneal sensation. In C, you can see the punched out margin. And E shows the healed ulcer. Now, case 2 is depicted in A. You see the punched out margin with a cotton wisp can be negotiated through the margin into the stroma, deep into up to the center. And in B, the case 3 is depicted where you can see a very delineated sharp margin, inferior margin shown by the arrow. And there is pulling of dye in the interlamellar space is shown in C, and D, healed ulcer. Now case 4, a case of bilateral herpetic keratitis, right eye show again very delineated sharp margin with, in C you see the plane of cleavage is shown by 2 small arrow and with a small area of desmodacil by big arrow. In the left eye, you can again see the sharply demarcated margin with pulling of dye in the interlamellar space, and the dye is reducing with the healing of ulcer is shown in F. Now case 5, again there is a deep gutter-like punched out margin all around, fluorescent being pulled in interlamellar space in B, and C shows healed ulcer. Case 6, again you see the scalpel cut as if the lower border is cut with scalpel. It is so precise. In B, you can see the interlamellar space fluorescent staining, and C and D, the healed ulcer. So our key message is, apart from dendritic geographical punctate ulcers at one end of the spectrum and neurotropic ulcer at the other, there seems to be another distinct group of infective herpetic ulcers in between. This group of ulcers may be named neuropathic ulcers. The area of cornea supplied by the affected nerve is separated from the normal cornea by a punched out border of demarcation followed by lamellar cleavage, following the architecture of lamellar-planar distribution of affected corneal nerve. Here you can see in the left lamellar-planar separation of cornea with anatomical correlate, that is lamellar-planar distribution of corneal nerve. It is taken from BJO. The lamellar separation can be demonstrated by the pulling of fluorescent dye in the cleaved interlamellar space and treatment with local acyclovir or ganciclovir and oral acyclovir established healing. Thank you.
So, how did you rule out fungal infection, fungal corneal ulcer? What kind of microbiological or molecular biologic study you have done to rule out? Is looking at it, you know that some of them is not, you cannot rule out fungal corneal ulcer.
Sir,
some of them is really, I know that neuropathic herpetic keratitis can be, but some of them look like an fungal corneal.
Sir, yes, it looks like, but it is a common misdiagnosis and it is a common differential diagnosis. But sir, all of the cases have some common characteristics. They have come to me after 15, 20, even after 1 month of therapy with antifungal or antibacterial medication. These are all failed cases with antibacterial and antifungal. Most of the cases, antifungal medication has failed. These are the cases, all these cases. Next thing is corneal sensation is diminished in all the cases. Next thing, the punched out margin. That is very correlative of the anatomical distribution of the corneal nerves, as depicted by some study in the BJO. They say that the anatomical distribution of the corneal nerves are at the 3 levels. That is at the subbasal, anterostomal, and the posterior stomal. So my theory is, and that's also correlated in the clinical findings.
So we'll have
that
to wind up, please. I'm so sorry to interrupt, but
Pardon?
we're running short on time.
Okay.
So, yeah,
I think I have answered to your question that these are the ulcers which has failed with antifungal therapy. That is my
Thank you, sir.
answer.
Thank you.
Thank you so much. I request Dr. Sudipta
Yes.
to call the next.
Yes, the next speaker is Dr. Priyanka Gandhi. Is she there? Yeah. Artificial Intelligence and Biomarkers, Future of Diabetic Eye Clinic.
To thank AIOS for this opportunity. So one of the most common problem in the diabetic clinic is the diabetic macular edema, multiple injections and treatments, recurrences, and variable outcomes. So what are we missing? So we dug deeper and we read about the biomarkers which are already established in literature in the diabetic retinopathy, and we conducted a study in which we also found that the ICAM and the cytokine relations are there between each other in diabetic retinopathy and macular edema, and in presence of the reduction of the VEGF levels. And various biomarkers were found in the retina, ocular surface, and optic nerve. So our goals of the study were to monitor the disease, selection of treatment modalities, and outcomes of the treatment. The objective was to explore the integration of AI models and biomarkers in diagnosis of diabetic macular edema within a clinical setting. The study was a prospective observational study, and which was approved by the Institutional Review Board. The demographics were 56% were males and 44% were females, which ranged from 35 years of age to 80 years. The methods were, we collected aqueous humor samples from the patients who underwent cataract surgery, which were healthy eyes, which were labeled as control group, and the DME patients were receiving injections. The sample size was 366. The biomarkers were studied with the help of a biomarker pathfinder kit, which studied the 8 biomarkers: interleukin 10, 1 beta, 6, 17A, MMP9, ICAM1, and VEGF-A and TNF alpha. And the AI model was used to generate diagnostic score and biomarker-based point of care for DME.
So the measurement of this biomarkers was done in aqueous humor. The aqueous samples was collected and the sample was added, mixed with the buffer and instilled in the cartridge of the biomarker kit, and which was then run into the machine to generate the biomarker profile. So here's a video showing the same. We stored the aqueous as minus 80 degrees. From here, I'm putting the buffer in the plain vial and then adding the sample to it. And this sample is added further into the circular wells. At a time, 32 samples can be tested in one cartridge. And the wash buffer is added in the horizontal wells, and then that is run in the machine, and it generates the biomarker profile. So then this data was inculcated in the AI work model. We tested random various models, but out of which random forest was the most accurate one, which helped us to get the results. So it had it predicted 84.3% right results with the control group and 76% for the DME. The various biomarkers that AI model compared, in which we found that the IL-10 and 17A were reduced in DME patients while the rest of them were high. And AI predicted the diagnostic score was 0.6 to 0.7. Clinically, we tested, here I'm showing an example where the PDA patient was with the right eye CME. We injected, at the time of injection, VEGF and ICAM was both high. And ranibizumab was injected, but persistent edema. At that time, we again did the biomarker profile and we found that the ICAM levels were still high, but the VEGF levels had come to normal as the control group. So then we gave steroids, and this shows the importance of the biomarker profile. So clinical impact of this is it is easy and quick. It only takes 90 minutes. AI-powered biomarker-based point of care, patient stratification, minimally invasive, multiple marker potential and integration potential, molecular with imaging and biomechanics. I would like to thank the NN team for all the work, clinical team, research team, and Dr. Rohit sir. Thank you.
Good and interesting work. Were your DME cases treatment naive?
Yes, ma'am, we had both of them actually. In this presentation, I have not included the treated ones. They were treatment naive, ma'am. But for the example I've showed the treated one to just show that in treatment naive as well as the treated, biomarker profile is helpful to treat further.
And what did the AI do in this?
So, ma'am, the AI, we wanted to test the AI model if we can predict with the biomarker data also that if it can classify into control groups and DME, if it can detect or not. So the diagnostic score itself is high, ma'am, with the AI model, using the AI model. So integrating it clinically, if we tomorrow in a rural setup, if we want to integrate AI and then refer the patients, it might be helpful in future, ma'am.
Yeah, but nobody's going to be sampling aqueous at a rural level, right?
Yes,
yeah? So basically, I understand the point of sampling the aqueous and looking at the biomarkers, and you can just statistically look at high levels. There doesn't seem to be much of an added role of AI, at least, unless it's going to look at the level of particular biomarkers and tell you either how much the macular edema is, like correlated to the OCT, central macular thickness, or predict response to treatment.
Yes, ma'am. So that is it is an ongoing study, ma'am, where we have integrated the OCT findings as well, and we've not presented it yet.
There's an offshoot of this study. IL-6 and IL-17 are inflammatory biomarkers. So do you think that diabetic retinopathy is basically an inflammatory disease?
So, sir, it's a diabetic retinopathy because we give multiple injections and we give anti-VEGF. So here we want to know what else is also playing a role. Here I've only compared ICAM and VEGF for simpler understanding, and due to lack of time, I did not show all the biomarkers that we tested. But there were IL-6 was also high in the DME patients.
That's a new concept.
Cost?
Thank you.
What is the cost?
So for the test, it might cost up to 2,000 to 3,000 for the test. And for the machines, we have the booth here, so they'll be they're launching at this conference, so that they'll be able to help more with the company.
Congratulations, Priyanka. You just finished within stipulated time.
Thank you.
Okay.
Thank you so much.
Thank you very much.
Please call the
next. Next is Dr. Shalin Sunil Shah. Are you there? Yes. Your topic is obstructed mammalian gland disease. Indian take on mask and probe.
Okay, so I'm presenting a very simple innovation as compared to the AI studies we have seen recently. So obstructive meibomian gland disease, these are the refractory cases where our typical treatments, warm compresses, repeated lid massages, oral doxy or azithromycins, topical antibiotics, nothing has worked. And these are usually patients from the poor socioeconomic strata who come to the charitable hospitals and the charitable OPDs, and they can't really afford the LipiFlow and other treatments that we are offering nowadays. So one of the landmark studies here was done by Dr. Maskin in 2010. He published this meibomian gland probing, where he introduced a steel probe into each of the meibomian gland orifices on the slit lamp. And after probing, he described that the patients had relief, and up to 12 months, he noted that there was lasting symptomatic relief. But, so this is the Maskin's probe, where the tip is introduced into each of the meibomian gland orifice, and they are available in 4 sizes, and 76 micron is the diameter. Now, this probe, it costs around $285 for 10 probes, and these are disposable probes. This is not actually affordable for our Indian population. So, and this study was then followed by another Chinese study who brought up the size from 76 micron to 160 micron, that is 0.16 mm, and they had similar results. So looking at the dimensions, we just thought what could be a cheaper alternative, and that would be a 34 gauge needle, which is used in the pharmacy trials for injecting the mice, and it is 0.159 millimeters, the outer diameter, and 4 mm in length. So it could be a very good replacement for Maskin's probe, that's what we thought. And then we used it on 20 patients. We anesthetized the lid margins using lignocaine jelly. Then we did warm compresses before for 15 minutes. Then each of the meibomian gland duct was dilated in upper lid as well as lower lid till a pop was heard. This is an audible pop which can be heard by the patient as well as the doctor, and the patient also feels a sense of relief just with that sound. And then the warm compresses were repeated for 15 minutes. So these are our patients at 3 months follow-up. You can see in the upper image the dilated and blocked meibomian glands, and in the lower image it has resolved. So we had 20 eyelids out of the 10 patients, and we followed them up for 3 months, and we excluded all patients with previous tarsal surgeries like entropion surgeries, and all patients of NLD or recurrent chronic dacryocystitis, whether active or treated, were also excluded. And most of our patients had they were in the old age, mean age of 55, and they had the disease for around 24 months, that is 2 years. And this is our meibomitis grade, which reduced from around 3.7 at enrollment, and we can see a persistently low grade of meibomitis over 3 months follow-up. And the pain score, which was done using the Likert scale, that also the patients had significant relief of pain, which was maintained for 3 months. I would like to add that the probing was done only once at the time of enrollment, and the effects were lasting for 3 months in the follow-up. And the Monk score for epiphora also reduced significantly among the patients. So what it adds is that the Western literature gives us a price of $28.5 per case, and we could bring it down to 10 rupees per case. It's a very simple procedure. You just have to probe each of the meibomian gland orifices, no learning curve, no pain, and the patient is reassured by that pop of each meibomian gland. So the patient hears around 80 pops for each eye, 40 in each eyelid. That's powerful. So that's kind of a placebo which works along with a therapeutic thing. So thank you.
How do you source those needles?
Sorry, ma'am?
How do you source those needles?
Ma'am, they are available on Amazon. They are available in the unsterile form. A pack of 100 is worth, I think, 1,000 rupees, and we just have to sterilize them. And we can use one needle for both the eyelids or 4 eyelids of a patient, but not for the other patients to avoid cross-contamination.
That's true. And the 34 gauge needle will go through the 40 pricks.
Yes.
It won't get bent or damaged.
Ma'am, it's a cannula. It's a 34 gauge cannula.
Yeah, but it won't, because 34 is thin. It's not going to get distorted.
Yes, ma'am. It's 0.16 mm, but we don't force them through the meibomian gland, or we can just perforate the conjunctiva and hit the globe or something. So gentle probing helps.
Thank you, Dr. Shaleen. We'll go on to the last talk now because we're running short of time.
Yeah.
So our last speaker is Dr. Abhishek Anand, and he'll be speaking on the multi-stage cutting ophthalmic device called the WIT rotor. Dr. Abhishek.
Thank you. Can I have the presentation? Okay, fine. So it's not on the main screen. Okay, hi everyone. I am Dr. Abhishek Anand. I am Associate Professor at IGMS Patna. And I would be pitching my new concept, that is WIT rotor, a new age vitrectomy cutter. Can I have the next slide, please? So basically, we all know that a higher cut rate translates into a more safety for any vitreous retina surgeon. And the existing vitrectomy cutters are basically work on a respiratory motion of pneumatic cutters, which limits the number of cuts per unit time. Can I have the back slide, please? Yeah, and the upper threshold currently is around 10,000 cuts per minute. And increasing the cut rate in a gluton-like cutter decreases the duty cycle. So we have two problems. One is the number of cuts that we want to increase. So in order to break this threshold of barrier, we propose that a rotating cutter can break this threshold which has been put by the reciprocity cutter or the gluton cutter, and we achieve a safer and faster removal of the vitreous gel. We want to achieve that, and what we do is that if you use a gluton type cutter, you can't do a multi-stage cutting. So if you use a rotatory cutter, then you can do a multi-stage cutting. So the innovation is that we made a casing that will house an electric rotating actuator, and which will be connected to the cutter through a coupler. The operator will switch the hand press, which will start the disposable motor. We initially want to achieve somewhere around 30,000 cuts per minute. The disposable motor will rotate at a multi-point cutter, and this multi-point cutting refers that the cutting is not done at the tip, but also in between the shaft also. And the best part is that it will have a modular design. So if any part falters, then you can just replace that part instead of changing the whole cutter. So these are the parts of it. There is a back blade, then you have the DC motor, then you have the aspiration line, the motor housing. You have the hollow shaft, which is outside, and then we have a solid cylinder, which is inside. So this is an animated design of this. So basically, this cutter has an outer housing, and this inside there, and this is the main part, which is the solid cylinder. And this solid cylinder, if you see, there are two cutting parts. One is in the middle, and another is at the end of the cutter, which is like a traditional. And there is a DC motor which drives it. And once you have the encasing of the solid cylinder, and then like a typical cutter, you can put it in the eye, and you start aspirating it, and then it starts aspirating. The only difference is that it will cut at 2 points. You can add more points if you want. Now this is the main design of the shaft that we have proposed for our patent filing. So we can see the 2 points of cutting. One is at point A and one is at the point B. So overall, what are the expected benefits is you want to achieve ultra high cut rate, you want to make it instrument cheap, you want to have more durability, low carbon footprint, and universal availability. So till now, we have crossed some parts of the journey like design and simulation, prototyping, and the IPR. So this is one of the first prototype which we used a Goda 23 gauge vitrectomy cutter, which won the first prize at the just concluded IIT TechMet, and we used the actuator and the coupler to show that it can actually work. This is our patent number, which will under the process. But overall, it's a very long road, and the main hurdle is the fabrication and the big budget that you require for it. So we are working on this. This is just a excerpt from our ICMR proposal that we have submitted for around 75 lakh of the budget that we want ICMR to support it. And we see that the fabrication process itself can take 36 months itself. So, and these are my partners in my journey. So thank you for listening to me. Thank you.
Why multi-level cutting?
So multi-level cutting is that when we go for a more finer gauge, then the vitreous sometimes clogs it, it decreases the cutting, and it sometimes inhibits the extrusion. So the point is to more faster removal, and the point is that we are getting this in a rotatory cutter. You can do that. It also acts as a support in the middle of the shaft also. So these are the two part of benefit.
So you are saying the vitreous which is cut by the tip of the probe, as it traverses through it, will keep getting cut. It's not multiple openings to the external.
No, only tip.
Yeah.
Dr. Abhishek, how do you sterilize it?
Sorry?
The motor is in the handpiece itself.
Sorry?
How do you sterilize it? Motor is in the handpiece.
So it will have, it's not like that it will have like a typical casing, it will be, we are still in the formation, but we think that the whole pressure where we'll hold it, that will have the encasing and that will be typical ETO sterilize, that is what we expect.
Thank you.
Thank you.
Thank you so much. With that, we come to the conclusion of this session. So, Dr. Jyotirmay Biswas has to leave. So, I would just request Dr. Niladri Saha to please give him a certificate of appreciation. Thank you, sir. I thank all the chairpersons for their presence here and all the judges. It was a pleasure having you. And I also congratulate all the speakers for the very excellent talks that they delivered. So we'll just have a quick certificate distribution ceremony. I request Dr. Niladri, we'll give the certificates to the speakers first. Dr. Niladri, to the first speaker, Dr. Ayushi. Dr. Ayushi, please come up. The judges, please.
Yeah, I don't know. We have to give to Dr. Tikku.
Dr. Sudipta, please give it. Dr. Tanmoy. Dr. Tanmoy. Dr. Prateek. I request Dr. Shyam Sundar, Brigadier Shyam Sundar, please give the certificate to Dr. Prateek. Dr. Pujita. Dr. Manavi Sendar, I would request you to please be honest. Dr. Partha Sarthi Roy, and I request Dr. Smita Shukla Singh to please give him a certificate of appreciation. Dr. Santosh Mahapatra, Dr. Koyal Chakrabarti, you can also join there. Dr. Priyanka Gandhi, and I request Dr. Santosh Bede to kindly give her the certificate. Shaleen Sunil Shah. Dr. Niladri, please. Dr. Abhishek Anand. Dr. Abhishek Anand. So we also have some certificates for our judges and chairpersons, which I'll be handing out. So, Dr. Sudipta.
Sudipta.
Dr. Sudipta, please. Please come faster.